Welcome to the EUPSA Webinar, Controversies in the Management of CPAM. My name is Martin Lacher. I have the privilege to chair this session together with Arnaud Bonnard from Paris, France, Paola Midrio from Treviso, Italy, and it's also an honor to have several to the EUPSA Webinar, Controversies in the order of their talks. I welcome Nigel Hall. He is Associate Professor and Consultant of Pediatric Surgery of the University of Southampton. Juan de Agustin, he is Professor of Surgery and Head of Department, University of Madrid. Martin Metzelder, he is Professor of Surgery, Head of Department at the University of Vienna. And Dr. Naziha Khen-Dunlop, she is Consultant of Pediatric Surgery at the Necker University in Paris, France, with a special interest and expertise in treating CPAM. So it's a true European endeavor we are doing today, if you still consider UK as a part of Europe. So, well, the format is like a scientific battle. We will have a pro talk and a con talk.
Naziha is a pediatric surgeon, famous pediatric surgeon from Necker Enfants Malades in Paris. And now she's going to talk about sparing surgery, trying to prove that the sparing surgery is superior to lobectomy.
So why such a question when, as it was said, not more than 30% of the pediatric surgeons do such a sparing surgery for lung malformation? So I will try to convince you. Next one, yeah. So first, because a pediatric surgeon thinks like this since always, preservation of the function and anticipation for the adulthood and the lifelong of our patients. So it was this kind of thought that was made for spleen surgery to preserve hymen function. It was also this kind of reflection for pancreatectomy surgery to prevent glycemic regulations, and also now for kidney surgery, not only when they are bilateral, but now even in unilateral form, just to preserve dialysis for the whole lifelong. So this point seems to be a key point for us, because we just think differently from adults, and we know nothing at the moment considering lung decline for the old generation, for the old or elderly. Next one, Gaia. So another argument could be that even adult surgeons move to that position, not for only patients, not in any cases, but even in oncologic disease, saying that in some cases it's a relevant solution and with results as good as the one obtained by lobectomy. So maybe, next, we should also consider this point for lung surgery. And actually, it's not a real new point, because the first publication considering sparing surgery was 40 years ago. In this, it's the first I found. And in this publication, the aim was already the preservation of the function, not for the adulthood, but for the lifelong of the patient. And in this case also, as you can see here, it was stated that the sparing of functional parenchyma should be proposed when possible. Next. What is clear is that lung anatomy is complex, more than for all the other organs, complex more than for the pancreas, spleen, ovary, or even liver. And moreover, malformations are not visibly, are sometimes not visibly macroscopically during the surgery, and so you cannot be sure of the limits, clearly. But if you propose, and then if you propose this sparing surgery, for sure you have to master the anatomy. And considering this point, lobectomy could appear more simple, because it's not easy. It's more easier, of course, to find the bronchus, to cut it, and to go. But moreover, this kind of resection, like Juan said, it is not that common in pediatric surgery. For pediatric surgeons, actually less more than in adult practice. So, because the indications are less frequent, this surgery are hardest, clearly, and then it definitely requires a well-prepared surgeon with a good 3D orientation in the chest, and we have to face with that and to deal with this complication. Next. But there are few publications, very few, considering this sparing surgery. And what are the facts? The fact is that it's feasible and safe. Easier, since thoracoscopy is used, and because thoracoscopy helped in the dissection. But anyway, and what we have to face with is that residual disease is the main problem. And this residual disease, of course, because of possible incomplete resection, is about 5% for the most gifted ones, as you can see, but more closer to 15% for all the other surgeons. So it is a key point of this surgery, and if you do so, definitely you have to deal with this and to accept this point. Next. The second point, yes, sorry, so it was next, Gaia. The second point and the second problem with this surgery is because the surgeon have to deal with a wide intersegmental dissection plane. So for sure, there are risks of air leaks postoperatively. But as you can see in this publication, most of all spontaneously heals, so no use for resurgery. And but what I can say about my own experience, that in children under 5 years old, ligature is definitely a good device and efficient for pneumostasis, with no need for a complementary stapling or so on, and it works quite well without, in my cases, no higher incidence of air leaks compared to lobectomy. Next. Now, it's true that it's not always easy to identify which segments are involved and which kind of surgery has to be done, especially when cysts are compressive. So in every cases, we have to take security margins. In this case, you can see that the extension was segment 7, 8, 9, 10. And so we did I did a resection of these segments, and the next one, Gaia, and the postoperative CT scan showed that only segment 6 was not involved and preserved, and you can see here that there's a small shift of the mediastinum, but no chest deformation, and a complete re-expansion of the lung, of course. Next. In this case, it was only segment 9. So here you can see the postoperative CT scan with next a fibrous band between segment 8 and 9, but not more than that. So quite satisfying. Next. But of course, and for sure, not all the malformations are an indication for sparing surgery. And in this case, next, it's definitely not an option. Next. So, is the sparing surgery feasible? Definitely yes. Is it superior? I think so. I think so because it can preserve normal lung tissue and then functional lung for the adulthood. And of course, as Nigel said it will prevent from chest deformation. So it has to be done when possible. Next. But there are limits of this surgery. We talked about it just before, so I will be short. The first limit is the age and the size of the patient, because even if some very gifted surgeon can do it anytime, anyway, after 6 months, it's much easier and better for many of us. Next. And in this publication, you can, next, sorry, Gaia. And in the next publication, you can see that the conclusion is timing of resection does not affect adverse surgical outcomes. So why not to wait a little bit after 6 months to propose this surgery if you think that it's feasible? Next. The second point is, of course, and we talked about it, and Juan talked about it a lot, about previous history of pneumonia and infection, and because it's a limitation for all surgeries. Next. Not only sparing surgery, but also lobectomy. Next, Gaia. And the last point for this surgery, difficult surgery, is that the third difficult point is the anesthesiologist. But I should not say that, otherwise my 3 dedicated anesthesiologists will not be happy and will not work with me anymore. But the point is that the ventilation is one of the key points of this thoracoscopic approach, and you have to be sure that the best is done to leave you the more space as possible. But once again, if you do lobectomy or sparing surgery, this is the limit. Next. Here you can see, with a complete exclusion of the lower of the lung, of the left lung, you can see that the malformatic area is quite well delimited, and then the segmentectomy and the parenchymal section appears very easy with a lot of space for this apical resection. Next, so definitely thoracic surgery is demanding, and thoracoscopy much more, and maybe sparing surgery much more again. But if you want to keep it, to make it superior, we have to do it properly. It means the good anatomy knowledge is needed, mastering the surgical techniques. It's really necessary. And the second point is that the patient follow-up is required with a CT scan control in every cases. So to make it good, valuable, and better than open lobectomy, than just lobectomy, these conditions are necessary. And of course, we have to accept this 15% of residual disease, but it means that in 85% of cases, it's a success, a complete success. And of course, we have to aware the parents of that, and they should agree with this option. Next. So why sparing surgery is, in my point of view, better than lobectomy? Because it provides organ sparing and then functional preservation for the future, because it's provide volume sparing and then reduced chest deformation. So in these cases, maybe we know, maybe we think, maybe we believe that there's a lung growth and compensation, but we don't know how much it will compensate. So the less you remove, the better results you will have. And after 4 or 5 years, there will be no more compensation at all. So for these cases, it's definitely a good option. Next. So my conclusion will be, sparing surgery is superior to lobectomy, yes. Next. But definitely not easier. Next. And for sure, not all cases are suitable. Thank you.
Well, thank you, Naziha, for this beautiful talk and also the clarity of your statement. One listener was asking, how do you ventilate the patient if you do thoracoscopic sparing surgery? Maybe you can comment on that?
Yes, I can. Of course, the best is an exclusion and selective ventilation. So after 30 kilograms, Callan's intubation is easier. Under 30 kilograms and for neonatal surgery, it's impossible. So if you work on the left side, a right intubation, selective right intubation could be an option. But of course, the best option will be a blocker, a tracheal blocker. But in these cases, it's not that easy to put, and it's really depending on your anesthesiologist. So it's not that easy. And if it's not possible at all, the only option will be a bipulmonary ventilation with low volume and high frequency. But in these cases, it's not that easier, and especially if there's a part of emphysematous zone, because the cyst definitely can be opened. The emphysema, not at all. So it's not easy, really. It's the key point. The ventilation and infection are the key points.
Okay, thank you very, very much. I think we are ready for the other corner of the boxing ring. Martin Metzelder from Vienna is talking about lobectomy and why he thinks this is the way to go.
Yeah, Martin, thank you very much for your kind introduction. I think the role I have to do is now to put some water in the wine. I don't want to be redundant. Please, next slide. So, of course, we are aware that we have paucity of data comparing segmental lung sparing resection compared to formal lobectomy. And for sure, there's, of course, a debate on the type of resection. Next slide, please. But what we have, and we heard that already, we have, of course, similar data on the complication rate. So in experienced hands, segmentectomy, in exclusive cases and lobectomy, irrespective of the approach, probably, either you choose VATS or thoracotomy, has the same complication rate. Next slide, please. For me, a major aspect is, to be honest, that we have a compensatory lung tissue growth following lobectomy in infants. I'm not talking about patients the age of 6 or 7 or 8 years. Of course, there is a nice role for segmental. So next slide, please. Here you see, and there are no real data on this. It's just experience, and I talked to other people who are dealing with this topic as well. So we can imagine that probably we have a lung growth capacity up to 2 years or even longer. And so I would like to favor lobectomy in this age group. Coming to a later age, I think lung growth capacity decreases with age. So in these cases, or in these age groups, of course, we have to think about sparing techniques. Next slide. Small lesions, wait and see, or segmentectomy. You showed, Naziha, a nice CT scan on segment, I think it was segment 7, one of the lower segments. In this area, if it is that small, I think I would wait. Okay, next. Area of the lesion plays a major role, I think. If my personal experience, I was in a trained adult surgeon, general surgeon as well. I had the luck that I was in thoracic surgery as well. So I feel that it differs, of course, in which area we are looking for. It makes sense, or it is, of course, an ideal area if we have our lesion in the upper part of the right or left lobe, and on the other hand, on the upper parts of the lower lobes. That is easier. Segment 6, to my mind, is easier than the others. Next slide, please. And what I think is, because there are more reports dealing with the success rates of segmentectomies than the other way around, and most reports, unfortunately, lack of description of resected segments and in detail lung sparing techniques. There's one exception, and somebody mentioned that study before. Rothenberg and his colleagues, it was a multi-center analysis. They performed really pure anatomic segment techniques, and they really mentioned where they resected. And the several other reports, they don't do that properly. Next, please. And so I feel that upper segments of upper lobes are easier to identify and to resect than some lower segments of lower lobes, where mostly the CPAMs are located. Next. For potential disadvantages, to keep it short. Risk of incomplete removal, risk of unintended injury of the neighborhood segments. To exclude residual disease, I really think that you need a CT scan and a longer period of follow-up, and sometimes even a reoperation. And in case of, if you need a redo operation, this is from Takahashi, this is a Japanese study, but this is on adults. But they mentioned that severe adhesions at the fissure. You have to look at the fissure to really find out the proper vessels before you dissect them. Next. And this is just a scheme from the books. And next, please. But it should remind you on the high variation pulmonary arterial branch supply. Next. So, in summary, if a pro for segmentectomy, of course I'm for segmentectomy as well, but we need a precise knowledge of anatomy. We have heard that before. We need to know, to be aware of anatomical variations of the lung architecture. I feel that we should be aware if there's an incomplete resection of CPAM type 1 or type 4, we have a major problem. I know that that Nigel will disagree with this, and I think that the excision of exemplary S3 or S7 is more difficult than other segments. And for lobectomy, lung growth up to the age of 2 years. Of course, if we have a large unilobar CPAM that is perfect technique, it is of course less suitable for multilobar unilateral lung involvement. And then we have to do one lobectomy and probably one segmentectomy. We can discuss if we can do it in the anatomic or non-anatomic fashion. And we need to avoid any injury of the adjacent segments. And if I have 2 more minutes, next please. I would like to share a case. There was a 1-year-old girl. You see the amount of the cysts in the upper lobe on the right side. Next. And unfortunately, Nigel is not with us, but that was his algorithm. And just in brief, I go through it. Next. The girl was symptomatic, showed up with respiratory symptoms. At the end, the DICER1 mutation was negative. I tell you later why we checked that. Of course, that was most likely to be a CPAM. This case, this mother had no prenatal investigation, so that was not detected before. And of course, it did not look like a PVV. Next. So next. So we performed just a lobectomy minimally invasively of the right upper lobe, and to have more space, we just opened the cystic areas, and in this case, we dissected the upper lobe bronchus with these locked clips. Next. But then the trouble started, because looking around exploration of other areas of the right lung, we noticed that there was a missed or underestimated cystic area of the apical area of the lower lobe. So what we did, we had no idea. We couldn't see it either on the CT scan in the OR. So what I did, I performed a non-anatomic dissection, a batch dissection with the stapler. And the histopathology revealed from the upper lobe, the type 4 and type 2 CPAM on the apical part of the lower lobe. Next. So going back to the algorithm from Feinberg and Naziha, bilateral or multi-segment involvement, that might be a problem. And at the end, we checked, of course, the DICER1 gene mutation that was negative, and we had no prenatal diagnosis. So what to do? We decided to do another CT scan of the chest, I think it was a year later. Next. And look at this. We had another cystic area at the former S6 position of the lower lobe. I mean, obviously the upper lobe was already resected, and the middle lobe was fine. So what we did, we took the patient again, minimally invasively, another wedge resection that revealed just a perifocal emphysema and no CPAP. We can discuss this case. Next. Thank you very much for your attention.
Thank you, Martin. I'll just try to answer to some questions on this Facebook page.
Oh, I've got a question for Naziha. Naziha, are the chances of leaving behind a part of the CPAM higher in cases of segmental resection than in lobectomy? What do you think?
Yes, the answer is yes, definitely. And it's a key point, because it's not that easy, because as Martin showed it, I think that sometimes it's more a local regional disease affecting the upper part of the lower lobe and the upper part of the lower lobe and the lower lobe with joint. Sometimes it's not that easy to know what kind to do. But I do believe that when you study precisely the preoperative CT scan, you can see it. And I agree, it's not that easy because the future in the young patients are not that easy to see. But you can imagine that maybe there's a problem on the area. But actually, the answer is yes. If you do segmentectomy, you are more risk of leaving residual cyst, and that's why definitely if you do segmentectomy, you have to schedule a controlled CT scan, and that's what I do. I also talk with the patient, with the parents of this risk, and of course they have to be agree with that. And I may say that in many cases they say, okay, maybe it's because they are too confident. They say, okay, let's go on for the sparing surgery because I think that it's better for my kid, and if so, we'll go to the other surgery. Of course, they think, believe, and hope that there will not be a second surgery. but they definitely should to be aware and agree with this plan.
I have a comment, Naziha. I think to follow up these patients, either those who are not operated or those who are wedge segmentectomy operated, is very important. And I do think the MRI, chest MRI, would be the future. And you and I have this expertise, not us, but our radiologists. So I would encourage definitely the radiologists to study strategies in this sense, because the technology is there, and I'm sure they are able to apply to the chest study also, because we cannot follow these patients with serial CT scan. That's too much radiation. And there is another type of technology that we should encourage.
Yes, I definitely agree. Yeah. It's huge work, but it will work. And even for non-operating patients, because the recommendation are to follow them all lifelong with CT scans, MRI would be and should be the best option, but we have to work hard on it. I agree, Paola. I agree, definitely.
There's another question from the audience about non-operative management. There were several questions on whether an X-ray is alone a good tool to rule out remaining CPAM, or whether you need a CT scanner or an MRI. What is your opinion on that?
So it's definitely not enough just an X-ray.
Juan wanted to talk about it, I think.
You need a CT scan.
Juan, what do you think?
This is a very, very important question, because we cannot rule out any lesion without having a good CT scan.
Yeah.
So just relying on X-ray alone is not enough to rule out a lesion or to say that lesion disappeared. So X-ray is not a good tool to follow up these patients. That's the problem with the long follow-up. You have to make CT scan or MRI, better MRI, as a follow-up tool. But a good CT scan is very good, at least as a first tool to diagnosing.
What is the ideal patient you do surgery on with a good feeling?
The ideal is the one that has no infection, previous infection. This is the ideal, because you can do thoracoscopy, and this is the perfect patient because it's easy to do. Also, you have to think about the lesion. If it's a CPAM or sequestration, always sequestration are much more better than, especially for starting doing thoracoscopy.
Yeah.
And what do you think below or younger or older than 6 months make difference in terms of lung exclusion and anesthesiologic skills? And what's your favorite age at which you operate the asymptomatic patients?
I don't think it's changed a lot between before 6 months or after 6 months. Most of the paper reported, especially on the effect of the general anesthesia on patients, or on patients less than 2 years old. So I don't think it's going to change between 6 or after 6 months. For the surgery, I don't like the exclusion and the single lung ventilations. I'd always use the bilateral ventilations and with CO2 insufflations. So it may be changed if you decided to operate on patients more than 6 months of age, because it's more easier to trying to do a single leg ventilations.
Do you always do anatomic segmentectomy thoracoscopically, or what do you decide on the method, surgical technique?
Okay, my clear answer and direct answer is no, not always. I know that what is recommended is a segmentectomy, but sometimes the lesion is so small and so easy to analyze in 3D view that I do wedge resection, and of course I always control the margins with the pathology, and of course all of them had a control CT scan. But my clear answer is no, not always an anatomical segmentectomy, as it was mainly required, I know. But I just may complete or add something to Arnaud, because I do not agree, of course. And I think that under 6 months of age, it's a little bit more difficult because of the space. And all the papers, I agree, Arnaud, all the papers are from expert teams, dedicated teams in thoracoscopic surgery. So all the results are with a little bias. And in my case, I know that sometimes I don't have my dedicated anesthesiologist. And I may say that for me, in youngest, smallest people, children, it's more hard. It's harder, definitely, because of the ventilation conditions. And I always insufflate CO2 also, but even like this, sometimes it's not always like it should be. So after 6 months, why not after 6 months? Because it was shown that the results are the same, and there's not a lot of infection in the first year. So why not choose the easiest way to do it? That's my point of view.
Can I ask the expert, in case of missing a fissure between lobes, so fissureless lungs, do you convert because you're not sure which lobe is which, or you try to dissect and go along? Because adult surgeons have their techniques, but in pediatrics, it's more difficult. So what's your experience with fissureless lungs?
I do not convert and try to make my fissure with a ligature dissection. I'm quite happy with it.
We do the same. We try to dissect the fissure and to open it to go to the hilum. I think most of the times you can do it with a ligature as well.
Yeah.
Martin has another question.
No, that's a comment. I mean, that really depends. If it is just an incomplete fissure, then it's of course easier than if there's no fissure at all. It depends what you're dealing with. Sometimes you cannot tell. Even if you try to start with the veins or whatever, you can do everything. But sometimes it really I think 1 or 2 cases, there was nothing. And
right.
I converted, and it was still difficult, to be honest. So conversion is not always easy, the problem. That's
I've got another comment on the surgical technique. So what we're doing it a hybrid technique. At the end of the surgery, after you take out a lobe, you have to do a little incision in the thorax to take the lung out. So we do this incision in the beginning. And then we are doing single lung ventilation. And then you can actually use also open instruments to operate. And when there is severe bleeding, you can just take an instrument and compress, put pressure on where it's bleeding, and then feel your own pulse first, get everything ready to maybe convert or to continue. But the pure thoracoscopic surgery is, I think, a little higher risk than if you do this 2 or 3 centimeter incision in the beginning and then have the beauty of controlling any bleeding very safely. Because in the end, you have to do the incision anyway to take the lobe out. So it makes no sense to do the operation with 3 millimeter instruments and then in the end do a big incision. So I think in terms of safety, we have to make sure that this is not an operation associated with mortality in the OR, because this is dangerous stuff. What are your thoughts on that?
Okay, and I of course agree, considering the safety. The point is that with the only totally thoracoscopic procedure, you can choose at the end of the surgery where you put your largest incision, and then you put it the much hided as possible. That's the only point. Huh? I may say it's a cosmetic and only a cosmetic point, but then you can hide it. So it's much nice, but not safer. Definitely not safer.
I would like to ask Naziha and Arnaud, because I've had the impression that you, Arnaud, you don't care because you're using CO2 for insufflation, and you do the very, very young infants as well, and you do segmentectomies as well. But it makes, for me, a difference if you do it at the later age, coming from adult surgeons. They always do it with blocked lungs, and that's a lot easier. So I bet Naziha could comment on this because it is probably easier. But you do not have any difficulties, is that right?
Definitely. Mine, we talked about it with Arnaud many times. Mine is easier because it's what I learned it, and because I found that there's no more risk for the patient, and that patient parents can easily wait 1 year or between 6 months and 1 year. Why not? What is clear for me also, what I learned from the parents is that after 1 year or if you schedule it too late, it's more difficult for the parents to accept the surgery. If we think that elective surgery is needed, it's more harder for them because they've seen their kids growing easily without any symptoms during more than 1 year, and then they change their mind considering the surgery. So yes, older than Arnaud, but around 1 year, not after. And yes, it's easier for me.
I mean, it depends how you have been trained and how your anesthesiologist team has been trained also.
Definitely.
And obviously, my team of anesthesiologists are not very well trained in blocker, and especially for if they want to use a Fogarty catheter for small babies, and it takes long times between patients and to be under general anesthesia, to be excluded for single line ventilations. So I found very easier to do bilateral ventilations with CO2 insufficiency, and we looked for the capnia during the surgery, and there were no hypercapnia, and especially on the very small baby, I'm doing between 3 to 5 months, and Steve is doing even before, and most of the time the fissure is complete. The surgery is very easy. It takes no long time to remove the lobectomy, about 1 hour without hypercapnia or something. So it really depends of how you have been trained and how your anesthesiologist team is trained. I really think so. That.
Of course.
Yeah, I think that single lung ventilation is a luxury, and when you can do it for lobectomy is wonderful. Is wonderful because fissures are easily seen and the hilum is very well controlled. So have a good anesthesiologist experience and help, you can do a much more safer operations. So I think it's important to schedule these patients and talk with the anesthesiologist team before scheduling in order to have a safe anesthesia.
There's another question on follow-up. So Juan, how long do you follow up and when do you say should be all right? So let's say there's a 14-year-old coming in which has been asymptomatic for the last 5 years, 10 years. How do you do your follow-up? And
yeah. We operate all patients, so I cannot say to you in asymptomatic observational patients, and we follow them until 16 years of age, but it's in a singular basis. It depends of the case, but if surgery is done early, you don't need to have many follow-up visits, but just to be sure, every 3-4 years to have at least an MRI in order to have the safe of complete remove lesions.
okay. There's another question on compensatory lung growth. Martin made it the point that if you operate early, it's more likely to be compensated. Martin, maybe you can make this point clear another time.
Well, there are no real data on this topic, to be honest. The only thing is, and that you can see by just an ordinary X-ray, plain X-ray, you see that there is a defect, and after a while, let's say it's simple, you see the whole cavity filled with lung tissue. But not in all cases. From time to time, you have a case. It looks like a hypoplastic lobe or something like that. We had that recently, and then the thymus comes over the side, and there's a mediastinal shift, and all these things that happens from time to time as well. And then you have to to monitor it. And at the end, I believe in the situation that you have really growth up to probably 2 or 3 or even longer in these age groups.
I think there is a study from Richard Kaiser showing that at the age of 2 years, right, the pulmonary function test was the same in the patients who underwent the surgery and later.
Yes, that's the line, of course, that's the line growth is probably about this year. Yeah.
Okay, I think we are ready. If there are no more burning questions, so what is the take-home message? Maybe all the speakers, I think Nigel left us to maybe do another surgery. What is your main message? Maybe just cut it down to surgery in asymptomatic patients, yes or no, and lobectomy versus segmentectomy. Arnaud, what is your maybe 2 sentences to each question? Lobectomy or segmentectomy?
So just coming from your questions about the ideal patients. So the ideal patients is the prenatal diagnosis with a CT scan in 2 months of life and a lobectomy thoracoscopically at 3 months of life, and the follow-up until 16 years of age, and especially with the respiratory function test at 6 years.
Great. Naziha, operating on asymptomatic patients, yes or no?
My answer will be: it depends on the kind of malformation. Yes, definitely for all cystic malformations, and depends for bronchopulmonary sequestration, and no for asymptomatic emphysema. This is my answer.
Great. So Martin, after this, these lot of punches by Naziha with her segmentectomy talk, would there be any patient now after listening to her talk that you would consider segmentectomy?
Oh yeah, I mean, I do lung sparing surgery as well, so there's no doubt. But what I've learned today is that I should wait a little longer and to monitor these patients with small lesions. And if my anesthetists give me the green light that I can do it under single lung ventilation, I go for the segmentectomy.
Great. Juan, would there be any patient where you would do thoracotomy right away from the start and not put a scope in?
Yes, I think the indication is in the first month of life. It's if you are going to do lobectomy, it's very safe for doing that. If you are going to do another kind of surgery, you can do it by thoracoscopy. But if you want to have a safe surgery and no complications in the first month of life, it's better to do thoracotomy.
Okay. And Paola, for the younger surgeons, they would ask you, what do you do to avoid severe bleeding? And what do you do if it bleeds like crazy?
You convert as fast as you can and scream for help, definitely. But your suggestion to make a mini thoracotomy since the beginning could be safer for the beginners, and never do thoracoscopic surgery without an expert in the room, and I would say scrubbed, because that really doesn't give you time.
Good. I think these are great last words. I think we have to close. We could talk on forever. And I thank everybody for joining this session. Also the 4 speakers, and Paola and Arnaud for chairing this session with me together. For me, it was a lot of fun. And I hope the EUPSA community enjoys this future format. And let's say we maybe cut a little bit together, and then we post it on YouTube for further studies. And I think we are all happy to answer additional questions. So if the audience wants to type in some more questions on the Facebook site, then we might address them within the next days and come up with a few short answers, if there are any answers to those questions. Okay, any more words?
Just one word, because I'm looking to the Facebook comments, so I see that it seems that we were not that clear in the answers. Actually, that many of them think that there's no take-home message or not clear. So what I may say is that we try to be as clear as possible. And when I could say also is that complex situations do not have simple solution. So we try to make a solution as best as possible. That's my comment.
Yeah. And one final comment. You may not see her, but Gaia should be really congratulated to set this all up and to be in the background and to get everybody, the EUPSA family, together as always. Gaia, thank you very much again. I have no flowers for you today, but I think your reward is that so many EUPSA family was online. So thank you very much, Gaia, again for this setting this up.
Thank you.
Yeah.
Thank you. It was fun.
Okay.
Thank you.
Bye-bye.
Bye-bye, everyone.
Bye. Bye.